Hey everybody, this is Pat with the Colorado Gerontological Society. I want to apologize that we did not get the May taping done the way we had anticipated. We had technical issues both on the hardware and the software. So we are taping this today. We will put it out in the system and send out emails. And there's also a couple of addendum items and the slideshow that you can request either from me directly or from the email. And so this is the third part of the emergency preparedness plan, and to start putting it all together. And so we'll get started. All right, so since April, we've been doing a lot of things and doing a lot of catch up, taking feedback from multiple entities and putting it all together into a process. Hopefully it'll make a lot of sense. So I can't believe it's June already and the flowers are blooming, and I feel like we are as well, even though COVID is still a piece of our life. If you need a review, on our YouTube channel is session 1 and 2. I've had calls from some of the administrators across the state that went back and rewatched them. And so, feel free to do that. Some of this is not new to you. Some of this is brand new to you. Okay. All right. So we need to be getting on our game and getting a bunch of stuff done before you don't feel like working because it's too hot, and be on top of it so that we can be ready for the fall, because we do have some things coming our way. So in Sector 2, I spent time on talking about the medication audits. And so let's review those things that'll make you successful. Master medication list is a must. I have developed a format or a tool to use if you don't have one. And then all you have to do is update any changes, new meds, discontinued meds, unless you have an electronic system that has that built in for you. I'm asking everybody to watch your PRNs, one for the cost, to the consumer. Number 2 is the documentation. Seems to be a frequent POC. The documentation don't make any sense. And that, and then when people use a routine or a PRN routinely, why wasn't it moved over to a routine medication, which will keep you out of the documentation other than the summary report that the clinician can do. All right. Remember, in memory cares, if you are a Section 25 memory care community, you cannot do PRNs. You cannot mask medications. You can't cut, crush, put them into food or anything else. For that community, and it's called masking. I've seen several POCs over that issue in the last few months, and we got to be extremely careful. We are not a nursing home, and therefore, and you guys are not CNA 2s. So no change of the medication. If they can't do something the resident can swallow, or they can't do something that's liquid, then we're going to have to rethink this. Same thing with injections. So all of a sudden we had injections showing up in the communities. No injections, and that includes insulin, okay? Please make sure that if you have a timed medication, it's important on a timed medication. So like it's a start this antibiotic 4 times a day for 10 days. You need to count out 40 doses, do the start date and the stop date, and make sure that that works, okay? So that is an essential piece of your practice, and that you've got the medications delivered and you actually get it started and you actually give all the doses, okay? And then please, on your refills, if it's missing, that's an incident report. It's considered neglect, especially for memory care or any memory issues that a resident has. They're relying on you to have the medicine and not to have a disruption in medication. Probably one of our #1 headaches and our #1 risk issues in medication delivery. The other thing, much to my surprise, is people counting the controlled drugs. And so big headache. If you happen to have a contract with VA, I'm thinking through with one facility that has quite a few veterans in it, how to do controlled drugs for the future, because they dispense so many medications. It was amazing to me that the feds are allowing that large a number to be dispensed in controlled drugs. but make sure your counts are accurate, and then make sure your destruction process is accurate, and that you are not putting it in cat litter, coffee grounds, any of those other things, because it's not a Chapter 7 issue. It's an OSHA and state issue. And they don't want it in the water, and they don't want it in the ground, and they don't want it in the trash process. They want it to go to the burn incinerator that we have a contract with in Wyoming. So if you are doing those old school ways of getting rid of meds, please get current and do the right thing for the right reasons. All right, so part 3, some common sense issues. Make sure you have the smoking and vaping signs. I prefer those ones that have the Colorado statue embedded on them. No smoking within 25 feet of the community, and that will protect you with fire and safety folks. That you have your fire retardant extinguishers, and that you have the right ones. Your fire marshal will be looking at those. And then you have anybody that smokes has a fire retardant trash can in their room. And it's not that we want them to smoke in their room, it's that we know that people have been doing things like putting hot butts in their pants pockets, and then getting to their rooms and their pants get awful hot, or they almost catch on fire, and then they throw everything in the trash can. And we've had a couple of fires. So fire retardant trash cans, and they're marked on the bottom that they're fire safety, and that's how the department will know you've got the right ones. As I've been going into facilities, I've started being out in the community more, and I'm noticing that the floors are taking a major beating. Make sure that everything's level, and that all your tiles are safe, and all of your flooring is safe, and that you don't have nicks and holes, and it's not beat up, because that's, again, another one of those POCs that I keep seeing. The second thing I'm noticing is that kitchen and dining room management has gone haywire, and we need to get back to our best practices that we were doing before COVID. And one of those is to remember that clean is clean and dirty is dirty. You cannot mix your utility centers up. So I've been in pantries where there is vacuums and mops and brooms. That's all considered dirty. Same thing in your laundry room. That is a clean environment. You cannot put dirty items in there. So you're going to have to figure out your house, whether you do a freestanding closet or whether you figure out something else. Also remember that you cannot put mop water in the general sink or down the toilet, because it goes in the wrong waste. It can go down a shower, but you will need to clean the shower from head to toe if you do so. It's preferred that you have a waste center where you can put those dirty fluids down. And so it goes into the potable water that can be treated. We've had some really strange weather already this spring, and people don't have generators, or their generators aren't working, and that can be a tag. You have to have a generator up within 15 to 20 minutes, and make sure that you have lights and heat, and that people on oxygen, if they're on concentrators, they should have an internal battery that is good for 2 hours. And you need to check those out. Some of these folks have had their concentrators for so long, their batteries are no longer functioning. Okay. The other thing I noticed is outdoor management has fallen off. So picking up trash, cigarette butts, pulling weeds, making sure your grass is cut, making sure your front looks like a hotel front, that it's inviting, and that everything's in good condition. So that's the other area that I'm seeing physical plant management has really fallen off. All right, so let's review a few things about COVID. The check-in process is not changed. So staff need to follow it. And what I've been thinking about is developing some sort of poster to put right in the check-in area to remind people to do it a linear process, to disinfect, use those cheap gloves that are not good for anything else, and then take the temperature, clean the thermometer, take the temperature, and then do all the documentation, throw the gloves in the trash, and hand a clean mask to the visitor. We do visitors still have to wear masks, whether we're in low or whether we're in high. They are masked when they're inside your facility. All right, you need a roster of your residents. If you don't have a tool, I have one that you may have. You also make sure your fire map is accurate and you know where your highest risk clients are. And then on your tool, you need to have the date for COVID shots 1 and 2, booster 1 and 2, and make sure those are kept up to date. And then have your vaccination plan to keep you through September of 22, because you are responsible, and they are calling for those plans to have had a COVID clinic already scheduled. That was due the first day of June. And so I see in those coming up and getting the scheduling done. We're having some pushback. People don't want to do the boosters. Staff don't want to do the boosters. And so fully vaccinated is shot 1, shot 2, and 4 months later, booster 1. And then I think it'll come out this coming Wednesday that the fully vaccinated will be redefined, and it'll be booster 2 4 months after booster 1. I suspect that the boosters have had to be changed because Omicron and Delta got married. And so their kids are looking a little different than where we were a year ago. And so the vaccines have been altered to be able to give your body the tools so that they can fight off both of those variants. All right. OSHA has, they got their hands slapped for a while, but they're back. And so here's their website and what they are doing. So they're concentrating on the N95s. And remember, they got a fit test. They got to be snug against the face. They're miserable. So you got to have a variety of sizes, small and medium and larges, if you have a variety of face shapes in your home. So you can't buy one fits all. That has pretty much a constant. It has to have the NUSH stamp on it. And this is a website to make sure that what you're buying is on the approved list. So CDC is, again, doing a lot of training. And so you've got to have frequent training and documentation of those trainings. And I would stay right on top of it for donning and doffing of gloves, donning and doffing of their masks, that they don't wear their mask outside the facility. If they go out for a break, their mask stays in the facility in a bag prior to the door going out. And they come in, they wash their face, they put their mask back on. So you need to think through some of this stuff, because those will be some really fast tags, and tags are going to start costing you a lot of money starting in August. I've had some questions about rapid testing, a lot of questions. Okay. RCF is very good about the guidance. Don't become overzealous or non-compliant. Residents do not have to be rapid tested every day that are not fully vaccinated. It's their right to refuse, or they may join it. And, that may not bother them. They're perfectly okay with that. Perfectly fine. Okay. Anybody that's rapid test, all your staff that's not fully vaccinated, is the ones that have to be rapid tested. Make sure you put that in simple reports on a daily basis. Okay. The other thing is, some of you called me or emailed me and said that you looked at your expiration date on your rapid test and they expired. Many of those have been extended, and on the website for both the manufacturer and the state, there is a link of how to check if your rapid tests are still good or whether they have expired and you need to get new ones from the state. Remember, you still can order supplies from Colorado. Okay. All right, your vaccination plan. Part of quality is planning. And so, again, you're being held accountable. Where's your plan? And have you updated it? Did you adjust it to meet the needs of your community? Or if you made addendums to it? And so it's not a one-time thing. It is pretty much a monthly review, and does it still work? And that's the best way to look at it. And so some pieces in it is that you've got the vaccination clinics assigned, that you are on good pace and you know the dates of when people need things. You know all your new residents, your new staff, the status of where they're at. And then you have your education documented of where it came from, and then that people attended it. You've got your lab documentation. You're doing infection control. You're, cleaning. So we've had, quite a bit of outbreaks in the last few weeks, and they last maybe 3 or 4 days, and then the second PCRs or the third PCRs are negative. People are forgetting to do some of the simpler infection control issues. So like cleaning doorknobs and using your fogger every day, and making sure that your linen rooms are well ventilated, and those types of things. So you may need to go back and review some of this area to see how you're doing or where you need to kick it up a few notches, okay? And then make sure that you are being due diligence on vaccinations. If they're not in CLIA, I'm not so sure that I accept their vaccination cards, because the fraud out there is beyond what I ever thought it could be. And so literally they were on Facebook Marketplace here a couple of weeks ago. Vaccination cards were available for purchase. Guess nothing should surprise me anymore. Okay. All right, testing. We went through a really little brief period of being low. We thought, oh, good, this will go all summer, we'll be good. Then we'll have our normal flu and COVID season, and we can get through this. Well, I didn't work. And we're back up to pretty darn high or substantially high. So follow the book, look at the testing grid, check your county status every Wednesday, and then follow the grid. What I've been thinking for a while is low is actually not something that we should pay attention to. We should do at least minimal weekly testing, especially everybody that's not fully vaccinated, and then biweekly testing as the guidelines tell you. And so what's driving this bus right now is the increased hospitalizations. And so every day, you know, we're seeing the numbers go up. People are not staying in the hospital as long. So that means that those hospitalization dates means that we're having a higher turnover. But because of some of the new treatment modalities and the ability to give the monoclonal cell treatments, they're able to actually get people back out. I just came from a meeting, a national meeting on long haulers, and getting doctors to understand long haulers and getting what does long haulers mean. And now that some of the doctors are long haulers themselves, and adjunct staff that worked in early COVID are really long haulers, I think it's getting more accepted that long hauling syndrome is a truism. Had a call earlier this week from a lady that lost her vision. She had COVID, and then a few weeks later developed another virus, and then a few weeks later developed another virus. And they thought it was viral meningitis. They're still not 100% clear what in the heck was going on with this lady, but she has subsequently lost her vision. And she's hunting all over the country for a doctor that can restore her vision, with high hopes that that'll happen. You know, Denver, we happen to have a major vision research division at Anschutz. And so I directed her back over to them to have this conversation, but I don't know the answer at all. And I've only known 2 people in the last few months that's reported that they've lost vision after having COVID. All right, so reporting, okay. Make sure you're keeping EM resource up and your COFI. And for those of you that have me on your notification list, you know, I watch them, and all I do is check to make sure that you got your numbers in the right place. Because occasionally it's when you're really tired, you put them in the wrong place. We get them fixed real fast. So that's only, that's my crosswalk for you guys. If you want me to be that second eye. And then remember that flu shots are mandated. They're not an option. So waivers are not going to hold you, because Chapter 2 has pretty much knocked out the waiver opportunity for flu shots. And I suspect in August now knocks out the waiver opportunity for COVID coming up as well with the booster shots. So I'm keeping an eye on that, trying to watch and see what civil rights and some of these other organizations are going to do, because it's not a Colorado topic, it's a national topic. So for all new employees, guys, they have to have a flu shot. Flu is here right now. It didn't even come when it normally does. It actually just arrived in the last 2 and 3 weeks. And some people are having flu and think they have COVID, or having COVID and think they have flu. So like I said, it's interesting clinically to see what's going on and how we're going to get through this new wave of bombarding us. All right, so let's get back to Q&P, because that's really what I want to talk about today. Remember, your quality management plan is a present to yourself. When you put the work into this and you get it done and you get it steady, your business will run so much smoother because you're following this process over and over and over. So the way to think about it, when we didn't know what COVID was and we were floundering all over the frickin' place 24 months ago, we really didn't have a rhythm. We didn't have a process, and we were, you know, we were doing a lot of things that we probably didn't have to do, and we weren't doing enough of what we needed to do. And then as it settled down and we got more knowledgeable and we got more processes in place and we got more conversation going on, we started doing better. And so this is what we need to do with the rest of our quality management plan, is get it all done, get it all ready to roll, make sure that all the parts are working, and then you should be good for the rest of this year and all of next. I have not been able to think of anything else that will get us in as much hassle as the last 6 months have done for our industry. So let's look back and just rethink about some things. Remember, you have a business. It has a model. The assisted living world has models. Even though the models are somewhat unique and different in a lot of ways, they're also very, very similar. And our similarity is Chapter 7 and Chapter 2. And then how you get paid. So there's basically 4 ways that services get paid for. And one is the state reimbursement, and the other 3 are one way or another that private pay is accomplished. Okay. Then you have your employees. And if you're still having high turnover, and you need to understand why, there is a webinar that just came out from the Eden Alternative folks on decreasing turnover and coming from the hotel industry. And so that is going to be available on the Pioneer Network's website shortly. I only got to see about 2/3 of it. It was well done and some really good points that I think you should think about it. So when you're looking at scheduling, one of the things you got to ask yourself is, how many hours are you short? I don't know how many administrators have told me they've had to work overnights or gap fill constantly because they can't fill those hours and they no longer can afford to use the agencies, or the agencies were sending people that it was a bigger problem to have them there than to work short. So again, you need to really understand that phenomenon in your life. What's the impact and how are you going to get out of that? Because you've got to have the time to be a good administrator to do the work that you need to do. Then you also have to look frequently at your risk acuity of your residents, and you need to understand that. I am playing with an acuity program with a fairly large facility, and we're starting to map it out and look at it. And I'm hoping that maybe by fall, we'll have something that's really useful. And then, we can put it out there. But an acuity means how much time does it really take to take care of that resident? And how much does that resident take care of themselves? And how do they interface with your agency? And how much do they understand about what assisted living means? And then how confident are you that your employees are well informed and what they're conversing with your residents actually is accurate, and that they are not going behind the scenes, go, oh, piss, you can get away with this, or you can go do this, or you can go do that. And nobody's going to care. Because again, that's not what our industry is about, nor has it ever been about that. It's always been about improving the lives of residents in a congregate living setting. So quality has parts. And so let's again review this. First of all, what are your issues? And your issues could be very different than anybody else's issues. Who are the players there to help you? Every staff person that works in your facility is a helper, and they all can take on and help support the end goals if they understand them. So if you have people that are not holding up or not doing their portion to be a helper, you may want to rethink about that position or that employee. What are your barriers? Why are you not having success, or why are you having success? And then what plans do you need to make to continue this continuum circle with quality management planning? Let's review what SWOT's all about. So SWOT is looking at 4 vectors in quality. One of them is strengths. What's the strength of the organization? One of them is weakness. Where are your holes? What things get you in trouble? What things do you, if you don't keep them done on time, they pile up, and then when you get to them, it's such a hassle to even begin to think how to catch up. What are the threats to the organization? I'll tell you, just last Friday was wild across the state, had multiple situations going on all at once. One of the craziest ones was up north. A gentleman got in trouble in his ACF. They were just kind of tired of him. They sent him in for mental health. He went to a day center. the day center immediately started calling communities to see if he could go to them, since he was uninvited from where he'd been living, which you can't quite do, but they did. And then somebody said, yes, they would look at his situation next week. The people over there didn't hear the rest of the sentence. They took yes, they sent him in a cab. He came with nothing. He's diabetic, lung disease, heart disease, no meds, no orders, no history, no nothing. And the lesson learned was she'll never say yes again. She will say, you can send over the referral and I will take a look at it with our consultant and we'll let you know if we have any interest. But that little yes created such a hullabaloo. And it took hours and hours to get this gentleman back to the hospital where he belonged in the first place, and then let their system deal with the situation instead of this drop off and you're out of our hair concept. And then what opportunities are in the future? What do you want to do? Do you want to expand? Do you want to change your target population? Do you want your staff to be more skilled? Do you want to do something else? I mean, what do you want? What opportunities do you want to look at? Do you want your paperwork and organization to be so smooth that it's seamless and you rarely have to go and invent a new wheel? Those are great opportunities to think about. So remember that you got in the business because you love people. You are in the business because you love people. You want to stay in the business because you love people, and you will remain in the business because you love people. All this other stuff you got to do because you love the people that you serve. All right, let's also review what risk means. So risk is broken into parts, and generally high risk is the ones that's in our face all the time. In our country and in other countries of the world, we've been running on high risk issues day in and day out, with the media and the news channels stirring the pot every 15 minutes, like gas prices, or this or that. And so therefore it feels like we're in this crisis mode on a constant basis. But we're seeing some significant increase of cost. And our reimbursement, especially from state funds, and our reimbursement from lower middle class or low middle class people, they really just don't have more money to live in a high end where they can stretch their dollars better. And so cost is making a huge impact in our industry. Some costs are more temporary and they're recoverable. And then other costs, you'll never see the money back. And so we're kind of fluctuating between this cost management issue. And then when you're stressed, your staff is stressed. When you're healthy and organized, the residents and the staff are healthier and organized. And so it makes a huge difference. Your leadership, your nonverbal and your verbal leadership, means everything in the world to about how well your facility is going to run. And then low risk is things that you got really good controls on. Your budget, your food ordering, your supply management, your vaccination clinics, your doctor visits, your reordering in pharmacy, your MARS sheets are going well, the staff's totally trained, get enough PPE. Those are great controls, and when they're in control, then all that stress goes down and your risk goes down along with it. One of the things that I think we lost sight of because of COVID and everybody's fears and anxieties and myths and what we knew and what we didn't know, and now what we're learning and what we still don't know, all of those issues are built into this trust and resilience. So as we are getting back to more stability in other industries as well, because that was very clear on the national discussion today, that under industries that are people-centered, okay, like we are, staff is returning because they're finding that these non-people related jobs are not for them. But we do have room we're going to have to make some new, I don't know, considerations is a word that I can think of at the moment, and figure out how we're going to invest in our staff so that they feel needed and important. So let's think about business risk, okay? So you may have some enormous mountains to climb right now. Your human resources may not be working at full speed ahead. You may need to purchase recorded videos for orientation so that you don't have to think about what goes in orientation. Some, a good handbook is important, having all your tools, having some pre-work done by the new employee before they come so they can be welcomed, they can shadow on the first day, because it's loud and clear nationally that they're not interested sitting 8 hours in orientation, whether it's a little company or a big company. They want to have that touch. And we cannot have them touch residents until they're fully done, but they can shadow and be a part of the community. We need to do more work in our houses, in our physical plants. We need to do more work inside and outside. One of the things that I'm keeping an eye on, don't know exactly where we're going to go, but ventilation has been identified that as one of the culprits for all of the SARS and all the flus and all the other stuff, is that our ventilation systems are not where they need to be. And the airline industry was way ahead of us and has done a lot of things and has stepped into our industry to be helpers, not for free, but to help us solve ventilation in our older buildings, and all our new builds have mandatory FGI requests for ventilation that'll have to be, and with code also for the city and county, that'll have to be met before they can even open. And then billing, Lord knows, single entry points, getting petties out, working with that team that does nothing but petties, and keeping on top of those and getting them renewed, getting the bridge to work, all of those things just has not been a good experience. So the health department, not the health department, but HICPUF has gotten a tremendous amount of feedback about this and is very aware, announced yesterday in a meeting that they're going back to the drawing board. I keep promoting or requesting or advocating, whatever word you want to use, that for all our new people coming into the HCBS product, that we forget all of this conflict-free case management, and that we have a team, a state team, not a county team, but a state team that does all of the initial HCBS assessments, gets them done really fast, 5 days. And especially people without assets. And then we don't have these period of times when our industry doesn't get paid, because we're at a point now, we will not take anybody without an approved HCBS petty payment. And so the hospitals or the shelters or HICPUF itself is going to go back to where we were a few years ago, and they will be sitting there until these are done. So they're very aware of it. The hospitals are not playing nice. They're not willing to have people sit in their spaces. Same thing with the rehab centers, all the different ones I'm talking to. We've got to have our authorizations done. So in business, if you have a referral and you don't have a petty, you can't take them until that is done. And so that's a risk issue for you, because you don't have the resources to sponsor somebody while the system decides to get things completed. Okay. Please also remember that you cannot manage resident funds. And so without a surety bond and a background check and blah, blah, blah. So I recommend you highly get out of that business. We do have some professional agencies that will be a rep payee for folks, and they charge them, I think it's $40 a month for even the SSI folks. So again, a change of business practices and protecting yourself is not taking care of people's money within your community. All right, so let's look at our care workers. The state calls them direct care working, and a moderate risk thing that is rolling out right now. And one is the direct care attestation. That was supposed to be done in January, and it was the increased wages. And you have to have proof in the pudding that you have those. And then the direct care worker IRS form. I've given those to Leah. I also have them so that we can get them to you. If you have not gotten the emails from the state or Department of Labor or your payroll folks, let me know and I'll help you with whatever you need to make sure that you're caught up in this area. Okay. All right, advanced directives. It's another topic area that we have to make some improvements. And so a lot of people have 5 wishes. That's really old school, not valuable. It's just a great place to start, but it's not, it doesn't hold any water anywhere. And so you got to have the most form. That is the most bottom line form that you can have in your community. You need that not only in the master electronic record or medical record, whatever you want to call it, for each resident, but you also want to have an emergency preparedness plan folder, and it will be a copy of that will be in there. Now, heads up, VA has their own internal form. That form is only good at VA clinics and in their hospital or nursing home systems. And they do not, the outside community doesn't particularly honor it. They'll push it over to a medical proxy. What I've been doing, and we'll see how this goes, is the veterans are, they just want to deal with VA. They don't want to play the outside game. So I'm attaching it to the VA form, to the most form, having a sign on the bottom of the most form to follow VA directives. We'll see if that works. And that was my workaround for veterans. If they have a living will or CPR form, any of those other advanced directives, that's perfectly fine, but we still have to have the most. So remember, the doctor reviews that with the resident at least once a year, okay? I have every advanced directive that I know about for our state, and we have YouTube training on our YouTube channel that Maria did for us a couple of years ago. They're well done, and so families can follow those along and accomplish them. Remember that none of these directives are permission to take people's rights away. They're only guidance and correlation of services. They are not moms and dads and people that think they're in power. They have no power other than to be a coordination service, okay? Other thing, this has also come up recently. If somebody crashes in your house, remember all staff must be trained in CPR and first aid, community level minimal, and they have to start CPR. EMS will take over CPR at that point, and in their ambulance, which is their own house, then they have protocols that they can activate with the command center, or sometimes they have to go to the hospital before they can stop CPR themselves. So even with the CPR, no CPR directive, it should be on the back door of each resident's room that wants it, so that they can take it with them. It doesn't mean that you are allowed not to start CPR. You must start CPR. And so we went through a spell where community said we are a no CPR community and thought they was going to get away with that. That was displaced about 3 years ago. We have staff say that my religion forbids me to do CPR, which is totally false, and they cannot work for you. So every person has to be certified in CPR. Every person must start CPR if there is a need, and if the person is without a pulse or not breathing or both. And the emergency staff will take the protocols from there and complete the situation. All right, so I wanted to kind of go back through some risk issues, and again, things that I hope that you are getting into place. So if you have behavioral health clients, please make sure you have the right records to support the situation. And if you're having medication errors, that is a super high. That includes where the pharmacy didn't deliver, the doctor didn't renew, the medication doses were changed, but you didn't get the information. The pharmacy got it, sent out the new one, but the paperwork didn't come. I've seen all kinds of scenarios. Any med error is super high risk. Falls is high risk, and so fall management is a big one. Elopement is huge. We just had recently a lady that eloped 3 times in the last 2 weeks before we went and took her rights away from her. Had doctors do an electrolyte evaluation, and those were off. And so she's getting some replacement. We'll see if she continues to be having dementia. I don't think so. I think it was delirium. And that gets missed a lot. Or if we're having aggressive behaviors, residents are hitting, or they're spitting at people, or they're chewing people out, some of the other crazy things that we're seeing with residents. Some other high risk issues is service plans, your rent agreements, your room management, HCBS final rules, anything doing with COVID, anything doing with infection control. If you are not right on top of all this stuff, use this next 60 days to get everything caught up so that you can have the next 18 months and have some room to think and do something more fun than chasing yourself. Here are some moderate issues. So on the behavioral side, member residents are not to be treated as second-class adults or little kids, all right? So we need to know what their preferences are. We need to engage them. And COVID, when we made everybody stay in their room, really disrupted this. And we need to start pulling the community engagement back together. We need to develop some new activities. Some people want, I mean, I've been asked by residents, when can we start doing bingo again? Well, do bingo again. It's perfectly fine. And they're willing to do some other new stuff. So, you know, we're looking at the communities, we're looking at new things, we're bringing back old things. And so they may have game night and bring out Parcheesi and some of those other old fashioned games, Canasta, 21, all of that. And some of the residents are just having a ball with that. They like it. Or they might do something new. There's some new stuff out there. So again, on the behavioral side, residents need to be engaged. It should not be in bed at 5 o'clock in the evening. You can have a great big party now that the Stanley Cup's going to be here. You know, you can do a lot of things, and you just got to get your activity and your resident engagement up. Okay. Some other things that is important is that you have really good tracking records so that your pre-admission stuff is done. You have all of the required assessments, and then you may have some additional assessments depending on your target population. I purposely stay with federally vetted assessment tools. The health department cannot challenge those. And so anything that the Alzheimer's Association's got posted, anything that the Parkinson's Association does, the Arthritic Association, some of these others, those are perfectly good tools because they're vetted and well respected. Just be, you know, aware that if there's a tool already ready to go, don't, you know, develop your own at this point. It's really not worth having a meltdown with the state when they come in and see your clients. So this is going to get really more important because House Bill, Senate Bill 22-154 did pass. The governor did sign them. As an agency, we had a lot of concerns about it. We did a tremendous amount of conversations with the industry. We're talking to legislators. We're talking to the governor, the governor's office, civil rights, you know, attorneys, all kind. I mean, I've never seen so many people engaged on a piece of legislation that impacts seniors or behavioral health as much as this one did. We didn't get very far, and I suspect it's going to create more of all of those issues. But one of the things is if you get a resident in and then you go for eviction, they're going to look to see if you did all your pre-assessment correctly. When I do the HCBS final rules, even if you don't do Medicaid, you are held to these exact same standards, no matter how you're paid. I encourage you to take this opportunity to, you can read them. They're on the state's website. You can attend my classes and I will be giving you the FAQ sheets, and they're more in detail than the classes are, but I'll be doing a discussion about them and then try to help you wrap your arms around it, because this legislation that went through is going to force this across the industry, and it will have equitability irregardless of how people are paid. All right, this is an example of some websites. So if you don't have a really good fall program and you want to look at something, so the My American Nurse has a really good fall program that's vetted. If you're having a pile of aggressive behaviors, again, in NurseLine under My American Nurse, they did a really cool campaign. And maybe you've tried some of these other systems and either it doesn't work in your brain, doesn't work in your community, residents aren't responding, whatever it is. Look at something else that is vetted and see if you can find some tools to move through these situations so that you can get them on the low end instead of them being on the high end. All right, so some more high care or high risk issues in memory care. All right, so you've got to have extremely well vetted documentation. of why somebody has to be in memory care. You do not have, nor do the family have, the right to restrict anybody in memory care from coming and going and being able to do their civil rights at their determination. Only guardianship court can do that. So we are having to really be very careful that, one, we vet carefully, and two, that we have all the documentation for that memory care to keep them out of trouble of just having somebody there because my daughter feels better, or the daughter felt better if she was in, behind locked doors. That will not hold water at all, okay? Your training has gone up. You're going to be doing at least 15 hours per year. So again, another legislation that went through. So not only in Chapter 7 do we have training under Section 25, now we have additional training under Section 25. And if you take any kind of memory loss, you'll have these same training modalities, the way that I'm understanding this legislation and when these rules go into effect. Eileen thinks it's going to be January. I think emergency rules will push it and it'll be in before September. There is some wonderful different trainings. And remember, not everybody learns the same way. So some people are auditory learners. Some people are kinetic learners, those folks that learn by doing. And some people are visual, they can read it, interpret it, and execute it. I'm not one of those. I'm a combination of kinetic and auditory. So when I do a lot of work in this area, sometimes it takes me 3 or 4 different methodologies before it all sticks and it makes sense to me. And every one of us has our own methodology of how we actually need to learn. And so you need to know your staff, you need to know yourself. Okay? All right, so in your quality, you must finish up your emergency evacuation and fire safety plan, okay? And so in the fire marshals discussions that I've been able to attend, and in some of the POCs that I have seen, in some of the situations that have been all over the state in the evacuation, so like the fire up in Boulder or the floods, or other things where electricity was out for multiple days, you've got to have an evacuation and fire safety. So just as a reminder, you should know what you're going to do. Do you have enough staff? Do you have an independent cell phone that's built to the house, and it is for your administrator to have on at all times so that they can use cloud storage and have essential information and have access to it without other people having access to it? Do not ask your staff to use their cell phones for business. How are you going to manage transportation? That was a mess in Superior. One facility, the school system was kind enough to send the buses through fire areas to get their residents and get them to safety, because originally the fire department told them to shelter in place, and then the fire jumped and then they had to move it, and they hadn't figured out the transportation by then. So again, we've learned. Go bags. Those have been popular for years. I have seen that fall off. So you need to get your go bags together, and then your families also, or their support systems, know that you may need some support if you're going to have to be out. You are responsible for 72 hours financially and physically and protective oversight. So you've got to think this and get this plan together, because they are being requested by the health department that you submit them. So I've seen this coming intermittently across the state, and administrators have called me and I've given them some stuff they needed real quick. So again, you may get an email from D. Rita and King saying, please submit to the following items. So they're looking at your fire policies, and then your practice drills, your outcomes, and then your updated certifications from the fire department, and that your fees are paid. So in the rural areas, a lot of times the volunteer fire departments have not charged assisted living, and all of a sudden they are. So that was a big surprise to many of them that have called me and asked me about it. So you need to know your own fire district and how that works. The bigger ones like South Metro, Denver, West Metro, Thornton, North Glen Fire Centers, they have really good websites. So you may want to croon in and see what you belong to. All right, so some checklists. Again, all your documentation's up to date. especially your training, the last PHO, the current RCF, which is 418, probably will be updated next Wednesday. And then guidelines, and then know where to go look at your county. Do not do the CDC, the news, your county website. They're all wrong. They're not accurately kept up. Only do the one website that the health department's put together. It's a rolling bar with the county and then the color and then what those colors mean, okay? You need in your fire and safety book, make sure you have your drills, your certificates are available, or at least you have a piece of paper in there saying where they are stored, that you have done your monthly alarm and sprinkler evaluation, that you've got a really tight lid on your smoking and residents aren't smoking on inside the house, which some communities are struggling with, and that you have all that together. And then you've got your medication audits, and then you should have a base quality management plan. And that's called the 9 elements. So we started teaching the 9 elements about 5 or 6 years ago. I just recently taught it to a group, and I need to talk to Eileen. We may put it on our YouTube channel so that you guys have it. It's the most common base tool for building quality. There's also a tool right above it called Plan, Act, See, Do, and it's based off of the 9 elements. Either one of those is fine. You just got to have one of those 2 in place, and you need to understand what a quality assessment improvement plan is, or a QAPI. And we all have them. And there's a variety of tools of how to build them. I like to use a graph insert on Word, on Microsoft Office Word, and I have a couple that I use all the time to show QAPI and mapping. I find that mapping speaks better to staff than a whole lot of language. All right. So as I said, the state's asking for you to submit some things. You may need some help. You may not have anything done. You may have to build everything from scratch. You know where you are. You know what you need. If you need to talk to me about it, it's a matter of picking up the phone. Okay. All right. So in conclusion, knock off this QMP drag. Let's get it done. Let's get it in place where you only have to do a little here, a little there, and it's not consuming. Okay. So last year in the POCs that I've helped with and some that I'm currently involved in, these were the topics of how they got impacted. And one of the ones that is really growing is social media. So please check your social media presence and see what's on there. You may need to hire a person that actually deals with cleaning up social media issues because the state's looking at your social media before they come and do your full inspection. Okay. So next, I'm very lucky. I have Lena to help me with taping and trying to get these things kind of more organized. So we're going to start taping next week, this 3-part series on the FAQs for HCBS. Again, I encourage all of you, no matter how you get paid, to go through these 3 sessions and wrap your arms around them, because remember this new legislation, what the indicator is what these 3 sessions talk about. No matter how you get paid, you will be held accountable to it. Okay. One of the things that I want you to think about, and I will talk when I do session 3, because that's all about resident agreements and service plans. Care plans is a nursing home model or a hospital model. Our industry is a non-medical model. Please don't call them care plans, they're service plans. Okay. Chapter 7 has some specific corp in the service plans, and then what enhanced services are, and then what are adjunct services such as home health or hospice or PTOT, or they go to a day center, or they go to mental health 2 times a week, or they go to this or they go to that. Those are adjunct services. So you're going to need to have a very person-centered resident service plan. And so we've been playing around with this for about a year. And I think we've come up with a model to kind of help with the conversation. And then I've been looking at some of the bigger companies like Point Click Care and some of these other plans out there, and trying to look at what they have and what can they do to help us, and can we get it all in one place so that it is centralized, and then the documentation is a whole lot easier. So that is where we're going and what my summer plans are. Our next administration training starts the middle of July. We are changing our modeling around. We're going to do 2 days a week for 3 weeks because of staff, people that have attended our classes have told us it's really hard to get all that time off. And 2 is that'll give us a chance to keep up with our workflow and still teach and be spot on and have the energy to give it high quality, which is, how Eileen and I feel about our education models. So we'll see you soon. Thanks for joining today. Feel free to call or to reach out on our website or reach out to me on my email, and we'll be glad to talk it out with you. Have a great day.